Hello, my name is Jessica, and today I will briefly go over Ards, prone positioning, and pulmonary blood flow with you. So let's talk about Ards. Ards is a condition in which fluid collects in the lungs air sac, depriving the organs of oxygen. Pulmonary blood flow. Its pulmonary circulation is the movement of blood from the heart to the lungs and back to the heart again. The oxygenated blood leaves the heart, goes to the lungs, and then re-enters the heart. The oxygenated blood leaves through the right ventricle through the pulmonary artery. Prone position is a body position in which one lies flat with the chest down and the back up. As you can see in this picture here, this is a gentleman that has R's that is placed in prone position. So now we will go over some of the anatomic alterations of the lungs. The lungs of patients affected by acute respiratory distress syndrome, also known as Ards, undergo similar anatomic changes, regardless of the cause of the disease. In response to injury, the pulmonary capillaries become engorged and the permeability of the alveolar capillary membrane increases. Interstitial and intra-alveolar edema and hemorrhage ensue, as well as scattered areas of hemorrhagic alveolar consolidation. These processes result in a decrease in alveolar surfactant and alveolar collapse or atelectasis. As the disease progresses, the intra-alveolar wall becomes lined with the thick, rippled hyaline membrane identical to the hyaline membrane seen in newborns with respiratory distress. The membrane contains fibrin and cellular debris. In prolonged cases, there are hyperplasia and swelling of the type 2 cells. Fibrin and exudate develop and lead to intraalveolar fibrosis. In gross appearance, the lungs of patients with Ards are heavy and red, beefy, or sometimes referred as liver-like. The anatomic alterations that develop in Ards create a restrictive lung disorder. The major pathologic and structural changes associated with Ards are interstitial and intra-alveolar edema and hemorrhage, alveolar consolidation, intra-alveolar hyaline membrane formation, pulmonary surfactant deficiency or abnormality, and atelectasis. So now let's discuss epidemiology and etiology. A multitude of causative factors may produce Ards, although more than 60 possible pulmonary insults have been identified to cause Ards. So I'm going to name a few of them: sepsis, aspiration, pneumonia, severe trauma, massive blood transfusions, lung and hematopoietic stem cell transplant, central nervous system disease, cardiopulmonary bypass, disseminated intravascular coagulation, inhalation of toxins and irritants can cause Ards. Only a few causes account for most cases of Ards. The clinical manifestations associated with Ards usually appear within 6 to 72 hours of an inciting event and worsens rapidly. The patient typically presents with dyspnea, cyanosis, bilateral crackles, tachypnea, tachycardia, diaphoresis, and use of accessory muscles of inspiration. A cough and chest pain may also be present. The general clinical course is characterized by several days of hypoxemia that requires moderate to high concentration of inspired oxygen. The bilateral alveolar infiltrates and diffuse crackles are persistent during this period, and the patient's overall health status is often fragile as a result of severe hypoxemia. Most patients who survive this initial clinical course begin to show oxygenation improvements and decreasing alveolar infiltrates over the next several days. Okay, so now I will go over the diagnostic criteria for Ards. Ards is a diagnosis of exclusion, that is, excluding other possible causes of hypoxemic respiratory failure with bilateral alveolar infiltrates. Cardiogenic pulmonary edema is one of the main alternatives that you would like to rule out. Other possible alternative causes of acute hypoxemic respiratory failure with bilateral alveolar infiltrates are diffuse alveolar hemorrhaging, idiopathic acute exacerbation of pre-existing interstitial lung diseases, acute eosinophilic pneumonia, and cryptogenic organizing pneumonia. So now we will go over the Berlin definition of Ards, the diagnostic criteria for Ards. Respiratory symptoms associated with Ards have manifested within 1 week of known clinical event or new or worsening symptoms over the past 7 days. Bilateral opacity similar to pulmonary edema appear on the chest radiograph or computed tomography scan. The opacities cannot be fully explained by pleural effusion, lobar or lung collapse, or pulmonary nodules. The patient's respiratory failure cannot be fully explained by heart failure or fluid overload. An objective assessment to rule out hydrostatic pulmonary edema is required if risk factors are not present for Ards. And you'll usually get an echocardiography for that. A moderate to severe impairment of oxygenation must be present, as defined by the ratio of arterial oxygen tension to fraction of inspired oxygen ratio. So whenever I refer to ratio, that's what I'm talking about, the arterial oxygen tension to fraction of inspired oxygen ratio. That's what I'm referring to when I use the word ratio. The severity of hypoxemia defines the severity of Ards. So mild Ards is defined by the ratio that is greater than 200 millimeters of mercury, but less than or equal to 300 millimeters of mercury on ventilator settings that include positive end expiratory pressure, also known as PEEP, or continuous positive pressure, also known as CPAP, of greater than 5 centimeters of water. Moderate R's is defined by the ratio that is greater than 100 millimeters of mercury, but less than or equal to 200 millimeters of mercury on ventilator settings that include a PEEP of greater than or equal to 5 centimeters of water. Severe R's is defined as the ratio that is less than or equal to 100 millimeters of mercury on ventilator settings that include PEEP greater than or equal to 5 centimeters of water. So we will talk about some clinical manifestations of Ards. Respiratory-wise, you'll experience some respiratory distress, fast breathing, shortness of breath, your whole body, you'll be low in oxygen in the body or possibly a fever. Some other common clinical manifestations would be blue skin from poor circulation, coughing, high carbon dioxide levels in the blood, muscle weakness, and multi-organ dysfunction. So now we will go over some general management of Ards. So you can give your patient oxygen therapy, which will help treat hypoxemia. It will also decrease the work of breathing and decrease myocardial work. You can also provide your patient with lung expansion through PEEP, which is positive in expiratory pressure, or continuous positive airway pressure. These are the key attempts to help to offset alveolar consolidation and atelectasis that is associated with Ards. You can also provide mechanical ventilation. It is usually needed to provide and support alveolar gas exchange and eventually return the patient to spontaneous breathing. Continuous mechanical ventilation is justified when acute ventilatory failure is thought to be reversible. Now, there are some ventilation strategies when it comes to R's that you have to take into consideration. For most patients in acute ventilatory failure caused by Ards, it is recommended that the patient is immediately placed on invasive ventilatory support rather than doing so of an initial non-invasive positive pressure ventilation. In addition to a full support mode of mechanical ventilation is recommended. Either volume limited or pressure limited modes of ventilations are acceptable when placing a patient on a ventilator. The recommended ventilator settings would be a low tidal volume and a high respiratory rate. The initial tidal volume usually is set at 8 milliliters per kilogram with a low plateau pressure over the next 3 to 4 hours. And the respiratory rate is usually set at 20 to 25 breaths per minute. Ideally, the plateau pressure should be maintained between 25 and 30 centimeters of water. If the plateau drops below 25 centimeters of water, the most common protocol is to increase the tidal volume per following ArdsNet protocol. Increase tidal volume by 1 milliliter per kilogram until the peak plat is greater than 25 centimeters of water. Or the tidal volume equals 60 millimeters per kilogram. Ventilatory rates as high as 35 breaths per minute may be needed to maintain an adequate minute ventilation for this patient. In the patient with Ards, a strategy of high PEEP is recommended when the ratio is less than 200 millimeters of mercury. For these patients, it is felt that the benefits of high PEEP strategy outweighs the possible negative pulmonary barotraumas. However, the optimal level of high PEEP has not been established.